I'd like to thank Dr. Rupak for the invitation and the IC course. So, we're talking about chronic postoperative endophthalmitis, which is basically defined as an infection after 6 weeks by a low virulence organism. So, you just heard about acute endophthalmitis. It's like that nightmare that wakes you up from sleep. Chronic postoperative endophthalmitis, one of my teachers told me, is more like polyuria. It doesn't let you sleep. Every 3 hours you have to go up and go to the bathroom. So that is basically the difference between acute endophthalmitis and chronic. We don't have correct rates of what is the incidence of chronic endophthalmitis, but there's one study which recommended at 0.017%, but the ratio between acute to chronic is anywhere between 2:1 to 5:1. So if acute endophthalmitis is like the movie Doom, what do you think chronic is like? Chronic is more like Devdas. There's always a background or a subliminal amount of sadness in the movie, and the intermission is the most enjoyable part of it. So it's a drama. Chronic postoperative endophthalmitis is a drama which has a deception, a revelations, players, and a twist and a climax. So what is a deception? It's important for an anterior segment surgeon to realize the deception. The deception is that you have a relatively quiet eye. It's a very low-grade inflammation in which you have, it responds to corticosteroids. The minute you take it off, it comes back. So the natural tendency is to think of it as a non-infectious entity. Then you have the exact opposite variety that the minute you give steroids, it worsens. And then the last presentation is probably having a vitritis in a quiet eye. So the main players in the drama is Propionibacterium acne, the fungal organisms, and the gram-positive species, the low-grade gram-positive species. There are a lot of other players. There are hundreds of reports bringing out different organisms. The roots are any particular root, but this is a very interesting root that you have to think about. It's mentioned specifically in P. acnes. That is a bad habit of some of the surgeons who take off the lens, put it on the ocular surface, watch it for some time, see how it's landing, and then take it and put it inside the eye. So of all the things, this could be an important thing to tell the juniors and the starting surgeons is that, and absolutely, once the IOL is out of its protective chamber, it goes to the next protective chamber that's inside the eye and you don't fiddle around it with anywhere. Coming to one of the main things we have got to think of, the P. acnes. The P. acnes is a very low grade, it's a saprophytic organism which is in the normal flora. It's a device that is created to sustain. That is, it resists all the activities of any killing. So it goes inside the organism and it avoids phagocytosis and phagocytolysis and all those things. It creates a biofilm around itself so that it gets protected. So you have an organism which it attracts all the cells, it is ingested by the cells, and it remains alive inside the cells. But it's not as innocuous as we think. Sometimes it just rampantly goes into severe vitreous inflammation, causes anterior segment problems like iris neovascularization, decompensation. And sometimes the very fact that a sequestered thing in a biofilm is released by an NDI capsulotomy sometimes. Fungi is the next important cause, and they resist the killing action of our own cells by having a very thick cell wall. To summarize, the basic features we have when you see a chronic postoperative endophthalmitis is a low-grade inflammation, which initially involves the anterior chamber, which is a key sign. And then if you're, seeing the patient, you see that it eventually progresses to the posterior chamber. Pain and discomfort is a plus minus, but decreased vision is usually a key associated feature. So the clinical presentation might be like a uveitis. You have a lot of large KPs and cells, and there may not be a frank hypopion, but sometimes on gonioscopy you can see a very micro hypopion. But this is a key point I'd like to make. Inflammation is usually steroid responsive, which means that it's such a low grade that when you give steroids, it improves. When you take the patient off steroids, it worsens. But then you have the paradoxical type. If it's a fungal infection, you can have a sudden worsening when the patient is on steroids. This is a key feature, the intracapsular plaque. You can see a whitish, it's half cut, you can see a whitish lesion. Sometimes you struggle to differentiate between retained cortex, but it's important to look at your post-operative notes to actually see how good your job was at that time and see whether is this a new feature or an old feature. This is just an interesting slide. Here you see a plaque. This patient was treated for P. acnes for months and months, and then this is a report, and a PCR was done and a culture on special media, and they found a new different species called acrimonium. So when you're dealing with chronic post-operative endothelial, you cannot have fixed ideas of saying that, okay, this is P. acnes or this is fungus. You've got to have a slightly open mind to it. Let's look at the vitreous activity. Usually the vitreous activity is very mild, but it can be dense when you're dealing with gram-positives, and you can have a pearl of string on-string appearance of fluff balls when you have fungal, but none of these are pathognomonic. These are only indicators to tell you what the organism you could be dealing with. So to summarize the features, being a doubting Thomas is the best thing. A recurrent inflammation in the white eye, having a decrease in vision, an altered response to steroids, which is a key feature, a variable vitreous involvement, and seeing of a capsular plaque. What is the revelation? The revelation, trying to find out, you have to take aqueous and vitreous samples. You may have to sample the plaque, but the important thing is that you cannot send it for a regular. You've got to tell your microbiologist that you want a prolonged culture up to 2 to 3 weeks, because all these organisms are slow going, and a PCR is a key feature. The PCR is wonderful for identifying the organism with one query. The query is that PCR is susceptible to contamination a lot. So it has to be a very sterile, pristine, virgin sample. And the PCR was important up to 84 to 92% it could identify the organism. There are some differential diagnoses like lens-induced uveitis, IOL-induced uveitis because of shaffing and malpositions, masquerade syndromes, and SIMPOF. The treatment options are a graded treatment option. This is a very nice thing to look at. First, you have just intraocular antibiotics, then you have your pars plana vitrectomy with the antibiotics, then you have a partial capsulectomy, then you do a total lens removal. I just have to tell you that the chronic post-operative endop does not follow the EBS study. So what is the twist? The twist is that managing is all about managing recurrences. So there are tailor-made options. Some studies have gone with the severity. Mild, you just give antibiotics. More severe, you do antibiotics with vitrectomy from capsulectomy. So are there any guidelines for us what to do? Some approaches went to the type of organism, which made sense. You don't treat a fungus the same way you treat a chronic gram-positive rod or a chronic positive foci. So epidermolysis, people have treated with just antibiotics alone, but P. acne, you have to take care of the capsule. So that itself changes the approach into these patients. The intravitreal antibiotics, if you don't have a culture report, you go by this thing. That is, the P. acne is the most common cause, therefore a broad spectrum vancomycin would be an initial good feature to start, good antibiotic to start with. There's a meta-analysis that told us that the outcomes differed based on these three things: the causative organism, the initial treatment, and the extent of intervention. If it was P. acnes, it had a better prognosis than for a fungal infection. That was a basic rule. So if you saw capsular plaque, you could think, okay, this patient could probably do better than a patient with just a posterior vitreous involvement and a huge amount of vitritis. So the chronic post-operatives had three approaches. That it required a vitrectomy with intravitreals, amphotericin, and voriconazole, but you had to give systemic antifungals, probably for a prolonged period also. So this is a key feature. You just do not send it to a vitreoretinal surgeon and he takes out the lens and takes out the vitreous. You just have to make sure that something like this, the patient receives oral antifungals also. The initial treatment. Patients who are just treated with antibiotics, 90% of them had recurrence. So that is not the way to go once you've diagnosed chronic post-operative. When pars plana vitrectomy was added, the recurrence improved. When you added the capsule removal, it again the recurrence rates decreased. How aggressive you are. Starting with just a vitrectomy with IOL removal, and it's just one more minute, please. With IOL removal, the recurrence rate was as low as 5% compared to 68% of patients when you just did a vitrectomy with intraocular antibiotics alone. So how aggressiveness is not a bad thing when you come to chronic postoperative endophthalmitis. This is a beautiful slide which is a meta-analysis which shows you that intraocular antibiotics, it had 93% recurrence. Only vitrectomy, 50% of recurrence. Vitrectomy plus removal of the posterior capsule, 26% recurrence. Vitrectomy, total removal of the capsule and IOL exchange. In this series, there was no recurrence at all. In a perfect world, we wouldn't be discussing about chronic postoperative endophthalmitis. In a nearly perfect world, this would be the sequence. You could do an AC tap with a PCR, a broad spectrum vancomycin irrigation, going with a vitreous tap later. This is a recommendation of the ESCRS that you have to give oral clarithromycin with moxifloxacin. PCR negative, culture negative, PCR positive, all have a PCR negative and culture negative. You look at non-infectious, but you look at other causes. The PCR negatives and the culture is positive, you think of contamination. If the PCR and the culture is positive, you can first treat with broad spectrum, and then you can go, if there's no response, go to an aggressive surgical treatment. A PCR positive and a culture negative, you can treat the same as this, but also you have to think of contamination also. The graded surgical approach is starting that you treat only with intravitreal antibiotics is not recommended. The best is to go with a partial capsulectomy at the first sitting, or if you think it is the disease process is more, go with a total capsular removal. This is a patient who received a partial capsulectomy in which you can see this is the plaque and it has been removed. This is a very interesting patient where you see this is not P. acnes. These are all fungal filaments from underneath the lens growing onto the capsule. Just going to put the short video. You can see the same patient over there. It started with removal of the lens, bisecting the IOL and bringing out the segments of the IOL. Removal of the capsule. You can see in both sides intraocular forceps is used to pull out the capsule in toto. All the bits are removed and by the cutter and by the intraocular forceps, and this would be probably continued with the vitrectomy. You can see it's a low-grade vitreous involvement. So this is my last slide. So you have to suspect it, you try to confirm it, use the clinical clues to try to find the organism, treat judiciously. But the main thing is that you do not have to be afraid of aggressive treatment when you're dealing with chronic post-operative endophthalmitis, and you have to anticipate recurrences. Thank you so much.